Why are we? Good evening, Endo Summit Live, and welcome to one of our most anticipated lives of the season. We are talking tailbone pain with none other than Dr. Amanda Olson. Dr. Amanda Olson will join us here tonight, and then she will do a full hour as we introduce breakout rooms as part of Endo Summit Workshop. So do make sure you try to stop by there. Welcome, Dr. Amanda. Can you introduce yourself to us?
Sure. Thanks so much for having me. I love being faculty here. I am a pelvic health physical therapist. I've been treating patients in that realm for roughly 15 years now. I specialize in pelvic pain and have a special heart for endometriosis. And then I'm also the president of Intimate Rose, where I create tools to help empower people to manage their pelvic health symptoms. And I do a lot of educating, and that's it in a nutshell.
Can you share, I know the story, but can you share a little bit about your own tailbone experience? Because I think that's what brought you to pelvic PT in the first place, right? Yeah.
I, similar to Sally, interestingly started my career in pediatrics, and I explicitly went to PT school to be a pediatric specialist. And I had a really rough fall from 40 feet. It was a jump. I was not pushed, but I landed in water in the shape of an L. And apparently, when you jump into water, you're supposed to land straight. But I considerably injured my pelvis and my pelvic floor, and very specifically my tailbone. And I had to go see a pelvic health colleague. And 15 years ago, I was so lucky because there weren't very many pelvic health specialists here in the United States. There was a couple hundred, and I got a very good one. And she worked with me and helped me heal up and really changed my life. And she told me, you need to quit pediatrics. You need to do pelvic health. There's not enough. And you have the right personality for it. So I went on to have two children and run marathons, and I'm active, and I manage all of my pelvic health symptoms with endo and the tailbone and all the things. And I'm really grateful and really lucky.
I find it really interesting that we both come from a pediatric background. I went to PT school not just to do pediatrics, but to do pediatric cranial sacral therapy. Like, could I have been any more targeted? And I think that that background in pediatrics gives you a background in neuromuscular pain, like in a way that I am trained orthopedically, but if that were my truest background, I wouldn't have that pain speak because you have to know the brain so well. Do you find that too?
Absolutely. Yes. I think it helps us know how to be creative with our body positioning in exercise prescription as well. And just really good at having a lot of different verbal cues. Because in pediatrics, the way that you speak to one child isn't necessarily going to elicit the response you need in another. So it's helpful to have a lot of different ways of explaining things and describing anatomy and function.
Yes. So we each have our models on our laps, which is also kind of funny that we're packing pelvises. Do you want to share? Let's break down the anatomy of the pelvis. Yours is better because it has a spine. Because I think sometimes people don't know. First of all, they never know what I mean by the ischial tuberosity, but sometimes they don't know what's hip pain, what could be groin pain, what spine pain, and what actual tailbone pain is.
Absolutely. And it's because it's a really high traffic environment. There's a lot of structures here. So here's the front of the pelvis and the back. And then this is the superficial layer of the pelvic floor muscles, everything that you see in red here. And you'll notice that it starts off the front of the pubic bone and then spans wide to the ischial tuberosities, which is what we feel when we sit. And then everybody comes back and joins onto the tailbone here. So we have a urethra, vaginal opening, and rectum here. Everyone has a pelvic floor. Everyone has them attaching onto the tailbone. So people of all different genders and ages and backgrounds can experience tailbone pain for one reason or another. The organs can be seen here. I'm going to dump them. We don't need those right now.
We're
There's,
gonna though, don't worry, we'll
yeah,
talk about it.
got him
Yeah.
in my lap. This is the deeper layer of the pelvic floor. Again, everything you see in red. And as I tip it forward, you see the pelvic floor muscles come very far forward onto the pubic bones here. They form a nice sling. They come very wide. So they do span out wide by the hip. And then again, all the way back to the tailbone here. So when we're talking about tailbone pain, there can be a lot of drivers. And in pelvic health physical therapy, we're very interested in the behavior of the pelvic floor muscles that impact the tailbone.
Right, can you do yours views better than mine, because my organs don't remove. Can
Oh,
you do this view again? Yes. So I want to show you while Amanda has that out. I do have a cursor, but I don't know if you can see it, everybody. So in the front, up against this pubic bone, and you see all the origins of the pelvic floor, that's where your bladder sits. So when we talk about in webinars, this one and other webinars, that the bladder relates to the pelvic floor and the rest of the pelvis as a sensory driver. You can really see in those pictures how it is so connected into everything. Now, Amanda, can you show everybody the SI joint and do, I know this is not an SI joint course. We're going to do that next year. Don't worry, but, you know, SI joint, spine, things like that.
yes. So here's the spine here. They look a little bit like elephants and they come up off of the base of the sacrum. The sacrum here, a lot of patients describe it as like a brick sensation in their pelvis. It is a bone that's shaped like a triangle and it has a lot of nerve roots that come out and then go into the pelvic floor. That's very important. These two joints here are the SI joints. They can be problematic in a lot of people that have low back pain. And one thing that's really important to point out is that pelvic floor issues, so pelvic floor muscles that may be too tight, maybe not strong enough, or maybe poorly coordinated, can contribute to issues, oftentimes overworking one particular side of the pelvis and the spine that can result in SI joint type pain. And then here's our friend, the tailbone here.
Right. So I really like to remind people that, and we did do a whole content on this. So that what happens here, right? And what happens, these are the innominate bones, these are the sacrum, right? So what happens here is really affected by what goes on in the rest of your leg, groin, and foot. And so sometimes when the pain is there, it's really coming from somewhere else and vice versa. I just, throw that out there. So I'll pinch hit for the endometriosis part, like I could handle that. So when you have endometriosis, you can, and actually Amanda's model is better than mine. I have model ending. But you can see on mine a little bit that, and I have a filter on, which is only making it worse, that the ovaries and the tubes can sort of lay up against those side walls, right? And so you can get hip and side wall pain from adhesions, from endometriomas, and from other issues. The other thing we like to talk about is that uteral sacral endometriosis can cause, see, I just want to show you how this is just the uterus sits inside this band of muscles, right? And any issue within the pelvis at all is going to spasm those muscles. That's why I like that pelvis maybe a little bit better than the one I have. So, so uteral sacral ligaments can cause a great deal of sacrum and tailbone pain and back pain because you're not getting the movement in the floor and the movement in the pelvis that you need. And so you're really putting a lot of pressure on that L5S1 and getting a lot of back pain and probably seeing a lot of back specialists who have no idea what endometriosis is. And then I also love to share that adenomyosis causes horrendous tailbone pain because the posterior portion of the uterus compresses the sacral nerves. Yeah, which will then in turn compress the tailbone and sacrum. And so my first endometriosis case, I get a call in those days, I worked with a very different kind of doctor. And I get a call at like midnight on a Sunday. You got to see this patient, like put him in tomorrow. And I was like sort of afraid to say no. So I put the patient in, and it turned out that the bands of adhesions in her rectovaginal septum, right? So that's the area behind the uterus, were so tight and so bad that they snapped the coccyx into multiple places. Multiple, we actually had like, they could see it on x-ray. They didn't I didn't that's how bad, because it's bone. You could see it on x-ray. And she had tried, and we didn't get to explain this anatomy. She had tried a series of 6 pudendal nerve injections, which, by the way, they're not even really in the same area. So you can get significant dysfunction to the coccyx and to the sacrum from endometriosis. Do you buy that the coccyx can sort of slip out of place? Like, or is that part of, there's a lot of discussion about that.
Yeah, I've not that I've observed clinically. I have observed people that have excessive motion. If I ask them to contract, there's a lot more motion than the 10 to 15 degrees that I would expect to see. And I have seen some post-birth, like childbirth injuries to where it's very rigid and it does appear to be in a fixed position following the birth that I have gently mobilized. But those were very rare and very traumatic childbirth injuries. So I don't think the most of our population is wandering around with a coccyx that is considerably out of place. I think it's a much more dynamic, musculoskeletally driven concept from that lens, outside of the presence of adhesions that could be possibly gripping it.
Right. So years ago, when Amanda and I first started, we were probably taught, this is what we were taught about the coccyx. None of this about how endometriosis and bladder endometriosis all relates with the pelvis. We weren't taught any of that. We were originally taught to go in rectally and to, with force, and I'm not kidding you, with force, strum this little tiny bone at the end of the coccyx. And that's how you should treat someone. And then when you take pelvic PT classes, we demo everything on each other. And I wasn't diagnosed yet. Somebody stuck their finger in there to demonstrate the strum technique. And I started screaming and started vomiting from the pain response. And I thought there has to be a better way to do this. Now, these days, no one is taught that technique anymore because it's useless. And so when you evaluate, somebody comes in, do you want to talk? You may not want to. Do we want to get to these?
Sure. What do you want to talk about with those?
Well, we should describe them, perhaps what runs between them. Your turn, because let me see if I can turn the filter off while you talk.
Okay, we've got sacrospinous ligament, and the pudendal nerve goes on a wild ride in and out of the pelvic musculature and around. But there can be some instances where there can be pain around these particular ligaments, especially if somebody's had a fall down to this area. But additionally, I always like to investigate what the behavior of the muscle on the other side is, because what I have found is that most of the time, if there's compression of the nerve structures or pain around this area, that I can address it by addressing the muscles.
Now, I was just about to say, we have a wonderful video of Dr. Fogelson, not only talking about the nerve, but talking about the venous supply that's there, which is very new research coming out. But look who's arrived. Who's probably exhausted. Everybody, like, be very grateful that he's here.
I just arrived.
Yes, you've arrived.
But it's dark. Sorry, it's not a very good picture. I'm
That's
literally
okay.
in my car.
People
I'm in
can
my
hear
car.
you. Welcome.
Thank you for having me. I'm sorry I'm late. I just finished 2 surgeries. Go ahead.
I know. We were saying you had a very long and arduous day, so we're grateful for you being here.
Oh, it was fine. But yeah, it was long.
Yeah. So do you want to talk? So we were doing anatomy. You don't have to do anatomy, but do you want to talk a little bit how endometriosis and adenomyosis may relate to sacrum and coccyx pain?
Um, you know, it's a good question. In some ways it does, but in often cases it doesn't. So adenomyosis should largely cause visceral pain. And coccyx pain is somatic, it's not visceral. So they really shouldn't cause each other, because your uterine pain is going to cause hypogastric nerve signals that are going to get up into your inferior hypogastric plexus. You should get a dull, aching pain into your back. You shouldn't get a sharp pain in your coccyx. Now, if you have endometriosis in the pelvic floor, like down in the cul-de-sac area, that can irritate those somatic nerve roots like S2, S3, S4, and those are going to give off branches. Those are creating the pudendal nerve, and a lot of the coccyx somatic nerve signals are coming up through the rectal branch of the pudendal nerve. And so endometriosis can definitely cause coccyx pain sometimes. Adenomyosis probably shouldn't. Things are weird, but I wouldn't be my first thought about adeno necessarily. But the thing about coccyx pain is, when I think about it neurologically, I mean, either the coccyx itself is injured, but usually that's not the case. Like if someone has a good mechanism of injury for having injured their coccyx, like they fell and they broke it, or then you could say, well, maybe that's actually an injury of the coccyx. But when people have coccydynia, like mostly I'm thinking that this was probably irritation of the rectal branch of the pudendal nerve somehow. If they don't have a good mechanism of injury for why the coccyx would be hurting, because it shouldn't hurt for no reason.
Amanda, I've only seen that one fractured coccyx, which happened from adhesions. You work in a more orthopedic, and childbirth, how many coccyx, like fractured coccyx have you seen?
I've not seen a fractured coccyx in 15 years of practice.
You used to see more because forceps deliveries. Sometimes you get a really difficult forceps delivery, particularly a rotational delivery on a patient with an epidural. The front coccyx can get fractured, which is awful. But I don't think you see them very much anymore. People fall hard, they can break it, right? You fall the right way.
Yeah, we have an interesting question, not to interrupt our webinar, but it's something I have not really answered before. What relationship does, and there's certainly a muscular answer, but then there's a different answer too. So does a bowel movement have, if that is reproducing sacrum and coccygeal pain? Let me go first to Dr. Fogelson and then to Amanda.
Oh, it's a great question. I'm not sure I have a perfect answer, but so could be a couple of ways. I mean, if the coccyx itself is painful from a actual injury, then you may be putting some pressure there as you bear down. Like that's possible. I think more what's happening is that the somatic sensation from the rectum and the somatic sensation from the coccyx is the same nerve pathway, and you're feeling coccyx pain when it really is probably more the bowel. Just like your shoulder hurts with diaphragm disease, it's the same nerve fibers that are coming up through there. And I think probably our brain is not very good at knowing the difference. And I suspect that the somatic part of the rectal innervation is being perceived as coccyx. Probably. I mean, I don't know that for sure, but I think that's probably part of it.
Now, Amanda, I know you're gonna have a very different answer because you were showing us on the pelvis very specific muscle groups. So if that were the case, what would you think about evaluating?
I would be very interested to know the coordination pattern when they are supposed to be dropping, relaxing, and elongating the pelvic floor muscles in service of having a smooth bowel movement. Because a lot of people paradoxically accidentally contract. It's involuntary. They're not meaning to, but when they're supposed to be relaxing and elongating to drop the pelvic floor, they can sometimes either experience a spasm or they can contract. And that, because the muscles attach onto the tailbone here, that could drive some spasm as they are bearing down to attempt.
Oh, yeah, that makes a lot of sense.
Yeah. Yeah, I think also it's not so uncommon to have gripping in those muscles. Do you see that happening, Amanda?
Yeah, absolutely. And I've spent a lot of time training bowel movement. It sounds, I know for a lot of people that sounds strange. But it is a little bit like learning how to ride a bicycle and people who have lost that coordination pattern. So we are teaching them how to notice that the pelvic floor muscles are up or on when they should in fact be dropping and relaxing and elongating. And there's a couple of different methods that we can use in a clinical setting to help teach that mechanism. And sometimes it may be teaching them how to perceive when the bowel is full, and then also working with dietitians and whatnot to ensure that the consistency of the stool is conducive to having a smooth bowel movement as well.
You know, it's funny. I always talk about, I never have the luxury. You know how there are some people who they'll only poop in one place, like they have to be home and have.
My
First of
daughter's
all,
like that.
but I travel so much for work, I don't have that luxury. But the other thing is, I have trained when to have these sensations but that when the bowel's full, you don't sit around and like not go. I know, but people do that. I mean, I'm also
My daughter's
single.
old school didn't have like the bottoms of the doors were open and stuff, and she refused. And now they just moved to a new location, and they've got these beautiful like full length doors, and now she's finally like willing to poop at school.
Yeah,
Oh,
but now we can save her pelvic floor. So we were talking about it before. Can you talk a little bit, Dr. Fogelson, about how the uterosacral ligaments may relate to the sacrum and to the coccyx and may cause some pain? What would be their referral patterns? A little bit, which is not always
Well,
standard.
sometimes I think that when people have really tight pelvic floor spasm, sometimes you'll have a patient where you pull on the uterosacral ligament, like you pull on the uterus a little bit, and they feel a severe pain in their pelvic floor. So the cervix, the uterosacral ligament, first of all, is not real. Like it's not a ligament. It's just a big fold of the presacral fascia. So there's a fascia that covers the sacrum, and then it takes a turn up, and then it kind of rolls over the top of the hypogastric nerve plexus, and then it rolls back out and sort of it's a weird shape, like it's a very complex shape of that whole fascia. And the part of that fold that sits between the cervix and the sacrum is what we call the uterosacral ligament. But it also continues down and becomes the sacrospinous ligament, which also becomes the arcus tendinea fascia pelvis. All of these pelvic structures are all connected by this fascia. So if you have the pelvic floor is tight and the pelvic floor is painful, and you pull on the uterus and you pull on the uterosacral ligament, you are effectively got a rope on the pelvic floor that you're pulling on that. And so if it's sensitive, you can create pain just by pulling on the uterosacral ligament, even if the uterosacral ligament is not diseased. Now, if the uterosacral ligament is diseased and it's all kind of gnarled up with endometriosis, then it's real stiff and you're going to be able to, it's not going to have any stretch to it. And you pull on it, you're going to be not only hurting in the ligament itself and getting both somatic and hypogastric pain, but then you're going to probably even more effectively be pulling on the pelvic floor also. Um, and I think that may be part of the mechanism of why people get pelvic floor spasm in endo is as that fascia gets kind of constricted, you're kind of chronically pulling on the pelvic floor fascia also, and that may over time develop spasm. The one thing I wanted to say from your previous topic is that so the common pudendal nerve, by that I mean the common branch before it ever starts branching out. Um, wait, no, I'm saying this wrong. The pudendal nerve, as it's coming underneath the sacrospinous ligament, it eventually enters the levator muscle and sort of the obturator internus muscle. So mostly the levator. And if that muscle's in spasm, it can create tension on the nerve or it can create some compression on the nerve, and that may cause coccyx pain, but it's also going to cause vulvar and like clitoral pain probably also. So, but that's another way that if a person has a really, really tight pelvic floor and they're having pudendal type symptoms, coccyx type symptoms, I'm often going to not only refer to PT, but also consider putting some Botox in there. And that can be helpful.
Yeah. I never knew the uterosacral fold, which you're right, it's more of a fold than a ligament, was contiguous with the ligaments that surround the pudendal nerve.
It is, yeah. It's and I didn't know that either until I studied, like, did the neuropelviology stuff, and you realize that all of this, all of this fascia is all connected. Like it's all one big, like
Yeah.
it's a very complex bowl of fascia that covers, that connects the entire inner surface of the pelvis.
It'll be interesting. So Dr. Chung is not here. He was signed up, but his research after like 10 years, I think as long as I've known him, he's been publishing this research. But his research is about to be published. It was accepted somewhere. I forget where it was accepted. And part of that research is in his protocol to downregulate pelvic pain. He does a pudendal nerve injection. Have you ever heard his lecture on this? And it's interesting that he does that and it just like wipes out the pain in the whole system, because look at what it's
Sometimes.
all the fascia that's it's connected to, you know. Anyway, so Amanda, somebody comes to your office, they have sacral and tailbone pain. How are you going to evaluate that?
I always start with a orthopedic exam. I look at them as a whole. I put them through some functional movements, including watching how they would stoop down to pick up a pencil that they dropped. I look at how their spine is moving. I look at how their hips are moving. So I'm measuring all of the different ranges of motion, how it flexes and extends and rotates, because the hip is partners, for better or for worse, with the pelvic floor. So I look at them from a more joint and functional movement standpoint, and then I assess abdominal function when they are lifting a leg. So then I start looking at how they're managing their trunk. And then from there, if the patient is ready on that particular day, I'll do an observation of their pelvic floor function and internal exam. Doesn't always happen on the first day, doesn't even always happen in the first month, depending on how the patient's doing. But what I do on observation is I'm asking them to elicit a certain response with their pelvic floor, and I'm looking to see if there's coordination in place to do that. So for example, I'll ask them to contract their pelvic floor. There's a lot of different ways to get that response, like asking them to shut off the flow of urine, or imagine they're pulling a blueberry up and in through their urethra or through the vaginal opening. And I'm looking to see if those muscles can close and lift. And then on the other side of that, I would ask them to bear down as if they were going to pass gas or have a bowel movement. And I'm looking to see if the pelvic floor drops and relaxes. It's not this much. It's very, very slight. It's more like this. But I'm looking to see if their brain and their pelvic floor are communicating and understanding each other. And then from there, internal examination, I'm palpating to determine if there's tender points and restrictions and areas that are reproducing the pain that they're experiencing, or even experiencing new pain. And then I'm also going to measure their strength and their ability to relax and the pliability of the pelvic floor muscles during that internal exam. Usually internal exam portions on eval only last like 15 minutes. And then from there, I have the information that I need to manage the tailbone pain.
Excellent. By the way, the comment on Facebook is, she's so smart and great. I just, you know, when somebody appreciates us.
I agree.
Yeah, I'm sorry, like, at least somebody appreciates the 60 years of schooling we had. Yes. So Dr. Fogelson, and it's different because your exam is very detailed, but somebody's primary complaint, in addition to bloating and menstrual cramping, would be sacrum and coccyx pain. What are you looking for in an evaluation?
Well, you know, interestingly, a few things. Some of and I'm really sorry. Can you tell me the name? Who's the other guest's name?
Amanda.
Amanda. Okay, Amanda. Thanks.
Yeah.
So, Amanda, I do some of what you're talking about, but I think not in as much detail as you are. I think of so I start with a really, really detailed understanding of what they're describing in their pain, and I try to get them just as detailed as possible to tell me if they're feeling, you know, whether the pains are sharp and dull, and if they can how they can make it worse and better, and if they're having pain with sex, pain with bowel movements, a lot of the kind of common questions. But one of the big things I'm trying to understand is the pain mostly visceral, or is it mostly somatic? So is it the dull, what you were talking about, the bloating and the dull aching pain, that's usually visceral. So it's hypogastric nerve irritation or uterus itself, like adenomyosis or bladder wall, possibly, or bowel. If they're having a real sharp coccyx pain, that's generally going to be a somatic pain, and it's going to be mediated through the lower sacral nerve roots. And so I'm going to do a neurologic exam, and I'm going to try to evaluate whether those nerve roots are acting appropriately. So I'm going to, there's not much in the feet for the S2 is probably the last nerve root you can get anything out of in the feet. So the flexion of the small toes is going to be S2. So, but I'm going to look at L4, L5, S1, S2. If you're making a nose because I'm wrong, maybe I am wrong.
No,
I have to go look it up.
I'm like clenching which toe, which,
Yeah.
driving the
So I know.
pedal.
So I
We
think
did
so.
stroke rehab, don't forget.
The ankle going up is L5. When it goes down, it's S1, and then the toes themselves, like stretching out the toes is S2 for the small toes. The big toe is still S1, and so it's hard to notice that. You don't see that very often, but if somebody has a notable weakness on one side, on the side where they have pain, um, then I'm concerned that there's literally something physically going on with S2, like endometriosis invading the wall of S2 or possibly multiple sclerosis. I mean, like if they have weakness, then they have axonal damage, and they literally have a dysfunctional physical nerve getting down there. And then that in turn could cause pain, of course. But that's actually fairly uncommon. But that's going to be part of my evaluation. Once you get down into S2, S3, S4, which is sort of coccyx, you have to look up at the perineum. So we're going to look at, do they have a good bulbospongiosis reflex? So when you touch the inside of their thigh, or you touch the labia, or you touch the scrotum in a man, you should get a contraction of the pelvic floor without them even trying. Like, you should get this kind of contraction, and you'll see the anus contract a little bit. You'll see the bottom of the vulva kind of contract a little bit. And interestingly, it's a measure of two things. One is it's a measure of the sensory function of the genital branch of the genitofemoral nerve, and then it's a measure of the motor function of the lower sacral nerve roots. And so they should have that cycle. And if they don't, there is something wrong with either the sensory function or the motor function. And usually they can tell you if it's a sensory, because they'll say, if they're numb, like if you say, well, I can't feel it, then it's sensory. But if they can feel it, but it's not causing the pelvic floor to contract, then it may be that there's some issues with those nerve roots. And then on the pelvic exam, your general gynecologist does a pelvic exam with the fingers going up. So they're feeling the cervix, they're feeling the uterosacral ligaments, they're feeling the uterus. But I'm going to do a pelvic exam with my fingers going down. I mean, I'm going to do both, but I'm going to do one going down. So I'm going to feel the coccyx. I'm going to feel the sacral foramina. So you can feel S2 and S3 foramina. If you reach up high and you have long fingers, you can feel S1 sometimes, but that starts to be too high. But you're going to push on those nerves and say, does it hurt to push right there? And does it create the pain? So if I push on, say, where S2 is coming out of the foramina, and they go, oh, wow, that really hurts when I push there, particularly if it maybe doesn't hurt as much on the other side, then you think, well, that nerve's probably irritated. And then you're going to think, well, why is it irritated? Is there endo there? Is there vascular compressions too? So sometimes there's vascular abnormalities that are creating some compression around a nerve root, and that nerve just being irritated may be being perceived as being coccyx pain. But like in that case, I should not be able to make it hurt by pushing on the coccyx. Like, if it hurts because of a nerve root irritated, like proximal nerve to the end organ, I should be able to push on the coccyx and it shouldn't hurt, other than just it's a little uncomfortable, but I shouldn't be able to make it really hurt by pushing on the coccyx. Whereas if I push on the coccyx and it really hurts, then there may be an injury of the coccyx, or there may be an injury of the muscles, like a tear in the muscles right there. And so, so you're thinking, like, is it the organ itself that is injured, or are we injured further up the neurologic pathway and we're just perceiving it in the organ? And so again, there's just a lot of little differential things, and you don't always know the answer. I mean, it's not like you always come out of this with an absolute answer, but you get closer to the answer, and then you get closer to some path you might want to take. And all of these patients, I would get into PT before I really do anything radical. Like, doing surgical stuff for this is kind of the the end game if we're not getting better. Removing endo is often going to be something we would do for just about anybody with pelvic pain. But if someone specifically had coccydynia and they don't have endo, I'm not operating on them until I've tried a lot of things, because the things that I could do are major and have their own downsides.
Very thorough. I have somebody commenting they've never had a doctor do the nerve roots. I think PTs do it because we all came from a stroke background where we're taught
Very
to
few
do.
do.
Right. Amanda, I have a question. Let's talk about pain in different, well, we could talk about this two ways. Pain in different positions, meaning standing, sitting, driving, and then there's pain in different positions. So maybe we should, Mariela, who's going to run Endo Summit Spanish, says we should be talking about both conversations because it's time somebody better talk about it. Yes, but pain in different positions, the first one. Then we'll talk about
Can
this.
I just give one comment on that, which
Yes.
is I universally tell my patients, don't do what's making it hurt. That, like, some people, like, don't push through the pain. If it hurts to sit, don't sit too much. And like, I've never seen someone naturally get better continuing to do the thing that's making it worse. And I think that some people kind of have like, well, I'm just going to push through the pain. I'm going to sit. Well, my butt's gotten totally numb and it's just, but I'm just going to keep doing it. And I think that's bad. Like, these things, they can heal over time, but if you continue to do the thing that's irritating it, that seems to be bad.
That's our culture as people with endometriosis, because no one, it's probably 7 stops and maybe 8, 10 years before they meet you who says that. And we needed to get through life. I see that a lot in, like, like if you told me don't go work out if it hurts, like I certainly would not have a national championship, but I never, even when we interviewed Tara Lipinski, there would be no gold medal there, because if you're in pain every day, you learn to push through it. And then you lose your ability to know when too much is too much. But that was not the general question. I wanted to talk about, like, some people have pain standing versus pain sitting. Do you have a commentary on that?
Sure. So activities of daily living and then sexual positions, were those the two that you were?
Yeah, those are the two. I think that tailbone for a lot of people can hurt a lot during sex.
Yeah, absolutely. So, from a therapy standpoint, we would be asking them what is needed throughout their day, and then we're thinking through the positions that are driving the pain and how can we alter that to get them more comfortable. Because just as Dr. Fogelson was saying, like, we don't want to be putting them in position to continue driving pain, because the pelvic floor is going to continue to ramp up and respond and drive more pain, and it becomes a cycle. So someone with a desk job, certainly we're going to be making recommendations to have the opportunity to have the sit to stand capability of their desk, hopefully. Even within that, having a place where they can prop one foot up, because it's not enough to just stand and be typing, because that eventually can take its toll on their back too. And oftentimes people with tailbone pain can have some low back pain. So having a little step, anything from 6 inches to 8 inches, depending on how tall you are, to prop one foot up and alternate. Certainly if they have a commute and they're driving in their car, they have to be seated for some period of time. So we may recommend a donut just to get them off of the tailbone during that commute time, or even during their desk time. And then just working to get them in different body positions to be mobilizing the joints around it and managing the pelvic floor. Teaching them good squat mechanics so that they are using their hips and their spine in an optimal way when they have to bend down to, pick up the laundry basket or the kiddo on the floor, those kinds of things. And then from a sexual standpoint, it does require really tailoring it to that unique person, because some positions for one person may drive pain in another, and certainly depending on if they have endo present. But depending on what kind of intercourse they're looking to have, always just recommending that they be creative, sometimes sideline is a great way to not be on it, first of all. And second of all, it tends to, if they're looking for penetration, to be a little bit more shallow, a little bit more superficially focused. And then also having them be in a position where they can control rate and depth of penetration, if that's the kind of intercourse that they're looking to have, so that they can be angling their body versus their partners.
I think it's also important when somebody when somebody has pain either standing or pain either sitting, that they're trained not to grip in their own muscles, right? So when you have pain, you normally splint against your own pain, whether you mean to do that or not. But then it becomes habit. And so oftentimes squeezing that glute just a little extra is gonna put a little too much on the pelvic floor a little
And
bit.
tucking, standing with their pelvis rolled under and tucking. And some people do it habitually and they're not necessarily aware it's just a posture they've always had. And then some people adopt that, and then it continues to put the shortening on the back side of the pelvic floor, the posterior pelvic floor muscles, that then perpetuates the muscle strain as well.
Now, we do in the real bank on the Instagram have me showing all these pelvic positions. But the funny part was that I am always a little tucked under, as is my father, as is my uncle. There's like definitely little nature versus nurture thing.
Sally,
And
are you
I,
saying that you're a tucker like like your father before you?
right,
You're a
I'm a
tucker, Sorrel. You're
exact,
a tucker,
but I
Sorrel,
couldn't
like
get
your
out of
father
the
was a
tuck
tucker
enough
before
to
you.
demonstrate it on Instagram. So there's no demonstration. And not only that, after Dr. Vidali watched that, he sort of suggested that perhaps, he was like, I don't know if that's a good angle, he said. I don't think that's a good angle. There might have been a discussion of GLP-1 medication after that. It was very traumatizing. But
Oh,
I think, yeah, I think
should put it in the water.
I also think, there are a million different kinds of pads for seats. There's not only a donut, there's different cutouts, and you really have to understand and they're all expensive. So you should know which one you need before you start buying them.
Well, and you should buy them from Amazon because you can always return it if it doesn't work.
Right. Right, for the most part, but that's why we spend so much time in anatomy. You can't see it. I have a lot of I actually had calcified endometriosis in part of my body near the tailbone. So I have like a little permanent tailbone pain, but I have a very unergonomic chair to anyone else in the world, but it allows the position of my sacrum to let me work. Now, then I bought a walking pad and a standing desk, and every time I go down to use it, my father is using it. So props for that. But I just want to say, like, even though somebody says this is the best chair, that may not suit your body, right?
When I moved from Atlanta to Oregon, I was in a Ryder truck for 4.5 days with very poor suspension and like no seat cushion. And I got a hell of a tailbone pain that lasted me a long time. It lasted like a year. And I have to give credit to my mother-in-law. And she recommended this seat cushion, which was this obus form seat cushion that's it's got a plastic bottom, so it's got good support. And then it's got a like Tempur-Pedic type material on the top. And for me, it was great. It was like, as soon as I started sitting in it, like it was a matter of a couple days, I was like a lot better. And so that particular thing worked good for me. God knows if, who knows if it's right for everybody, but that was good. But
I
that
do
was a
think shocks in a
physical
car.
issue. Like it was
Yeah.
literally, I think my tailbone was bruised.
Shocks in a car are a very documented thing with tailbone pain. I worked a lot of spine at one point, very common thing, right? And you see that, Amanda, right?
Yeah, absolutely. Truck drivers, people that drive heavy machinery. Yeah.
Yeah. And machinery, not that we do this so much, machinery that vibrates excessively, not a treasure for your pelvic nerves.
And I
Motorcycle.
think people that are a little heavier are probably somewhat protected from it too, because they've got just more padding underneath there. as
Well,
opposed
actually,
to someone's
one of
real
the
thin.
worst herniations I saw, a truck driver, very overweight. Also, they sit in they don't do it as much anymore, but they sit in the truck and eat, and he just blew his discs. Because it's expensive to do the shocks on the truck. Yeah.
Yeah.
Yeah. But your body pays for it. Anyway, we are rounding out. So are there sort of red flags? I'll ask you each this. If you're seeing tailbone pain in a teen versus in an adult, Dr. Fogelson.
I don't see that many teens. I don't think so. I mean, not in my mind. There certainly may be that I'm not aware of. I mean, I would say my assessment of it isn't going to change that much from the way I think about it. So not off the top of my head, because anatomically it shouldn't be much different.
Amanda, tailbone pain in a teen versus in an adult?
I see actually quite a bit. Dancers, particularly a lot of adolescent dancers that are in a lot of posterior tilt. And then teens that are really slumped in those awful education chairs that are very hard
Yeah.
for long periods of time. So I have seen quite a handful of that. I would certainly be very careful in the history taking to be determining, does it change? Is it consistent and it does not change and it's the same level of pain in the same location no matter what you do? Or are there some oscillations in it? Because I would expect there to be some changes in it throughout the day or with activity flared up versus maybe in a little bit less pain state. Because if there's nothing that's altering this pain, I certainly want to be referring back to primary care and possibly specialty, whether it's gastroenterology or perhaps gynecology, depending on the age, to determine if there's something more serious at stake than the musculoskeletal lens that I'm looking at them through.
Right. And I
Yeah,
think
I see.
that like from my point of view, my job, or what as I see my job, is to look like, is there something structurally wrong that is modifiable as a surgeon, either through me giving some minor advice versus intervening, where I could really fix something. And that's not going to be very common in a teen, but even not like tailbone pain is not something I'm going to operate a whole lot. Like a patient that I operate may have that, and what I do may help in a couple cases, but it's not commonly a reason why I would operate. Whereas I'm going to refer all those patients to a PT, and they're going to, if they're good, they're going to have all those conversations, and they're going to have really detailed conversations about what are they doing with their posture and their activity, and that's why it's great to have colleagues, because I mean that's not only not what I know as much about, but I also don't invest my time in that. I invested in neurologic evaluation and the things that I do. So, obviously we're not interchangeable, and it's really important to have both the PT perspective and the other perspective. And honestly, the PT perspective is the first place you go, and it may be the last place you go. It may be all, hopefully it's all you need, because what I have to offer for this particular condition is limited. Like there are occasional patients who I think have a literal pudendal nerve entrapment, and a pudendal nerve decompression may benefit them, but that's not that common, to be honest. Like that's not a common procedure that we do.
Yeah, in the area that I live in, there's a lot of horseback riding, there's a lot of
Yeah.
dance, obviously gymnastics, but there's also some diving, like some competitive diving. And we see coccyx pain in all of those. And then I also see those women oftentimes about 10 years later. And what happens is they were horseback riders, and so they had coccyx pain. They go to the doctor tells them it's from the horseback riding. They go through years of rehab, and then it turns out in the end that it was part of the cycle of minimization that comes with endometriosis. Now, that's because of my sample size, right? I get those patients because they're seeking me for that. But I do see quite a bit of that, and I see it in the dancers. And I see the dancers like also being told it's because they're not eating enough. It's because their periods are bad because they're, training so hard, and all of that is sort of the cycle of gaslighting that we get in endometriosis, which that's not a real study. It's just a my personal clinical experience. And you see that in horseback riders too. I see you nodding.
Absolutely.
You know,
And
what's interesting is I see it. Sounds kind of weird, but it's worth mentioning. I see some population of patients who have developed pelvic floor injuries through kind of unusual sexual practices. And every now and then I go like, we're really kind of a liberated sexual world where it's like, whatever you like doing is great. Like, do whatever you like. But like, from a point of view of like understanding anatomically, I'm like, well, these structures are fragile to a certain extent. Like you can't do anything, you know? And I've seen men with certain practices that led to having pelvic floor injuries. I've seen women that have certain practices that led to pelvic floor injuries. And so what I would say is do what you like in the bedroom, but if something is hurting you, don't do it. Even if you enjoy it, if it's causing like you have pain afterwards, it's probably not a good thing to keep doing, because I've seen patients have like permanent pelvic floor injury that seems very hard to reverse. And it clearly came from just getting into a habit of doing something in their sexual practices that just was creating chronic strain in their pelvic floor. And so I think you have to take a grain of salt to this idea that like everything is okay in the bedroom. Like it's okay, but you can injure yourself. So trust your body that if it's painful, don't do it.
You can injure yourself being very vanilla too. So,
Yeah. Yeah,
that
fair enough.
happens too. So we have a good question. What would you, regarding tailbone pain, what would you bring up to your endometriosis specialist? Is there any particular, somebody who may be going to the doctor in the next couple of months? Is there anything particular you would encourage them to share with their doctor? We'll go first to Nick and then to Amanda.
I'm sorry, Sally. I didn't quite understand the question. Can you refer, or Amanda answer it, and then maybe I'll understand what you're asking.
What type of questions should a patient ask their doctor regarding their tailbone pain? What should they go in armed with knowledge to their
Well, I think that if they're concerned about endometriosis, I think that ultimately you want to make sure that we get a good evaluation of the posterior compartment. I mean, any kind of reputable endometriosis surgeon should be doing that as part of their routine practice. But if there are like really, really notable coccyx pains, I would just add this, that you might want to get an MRI, because I mean, you can have skip lesions in the deep retroperitoneum where the pelvis looks relatively okay or doesn't look too bad, but there's a really deep lesion way down in the back of the pelvis. And you may feel that on pelvic exam if you're astute with your exam, but like, again, you'd have to have your hand facing down to feel that. But you may see it on an MRI. Like I've seen some people that have a remarkable amount of endometriosis in a pelvis that looks pretty normal, and it's out in the retroperitoneum, and they could get coccyx pain, they could get sciatic pain. I mean, this is a really kind of a high level endometriosis stuff, to be honest, but it's something to think about. Like that is a patient where I might consider getting an MRI over another patient potentially.
Excellent. Oh, we have one question coming in off of LinkedIn, which I often forget to check. And it's for Dr. Fogelson, and that's just the question is, what is your opinion on a coccyx surgery if the pain is significant and it's not responding to conservative treatment? So I guess she's talking like
well, the coccyx surgery being coccygectomy.
Yeah.
I think coccygectomies are, well, listen, I mean, if people have had a coccygectomy and they got better, they probably never came to me and told me about it. So I've never seen anybody get better from a coccygectomy. But to be fair, people that got better probably never came to me. I mean, I think that if the coccyx is hurting, okay, like you broke your coccyx and you have a neuroma in your coccyx because you broke it and it healed badly, and now you've got a chronic neurologic pain coming from your coccyx, maybe a coccygectomy makes sense. Just like we take out a uterus if it's got adenomyosis. I think you just got to be really, really careful that you're not in the hands of an orthopedic surgeon that just doesn't know what to do with you and says, well, let's just take out your coccyx, because it's not going to work. You know, if you better be damn sure that the pain is actually coming from your coccyx and not referred pain that you are perceiving in being in your coccyx, because that is not going to get better by taking out your coccyx. In fact, probably going to get worse. And so I would be step very carefully into that surgery and get a lot of opinions. I would not just jump into that.
Excellent. Okay, so rounding out our hour, Amanda will be giving our full hour in tailbone pain at Endo Summit workshop on March 9th. So it's interesting for you all to know the virtual component will be hosting that workshop as opposed to the 2 other workshops. So Amanda will be broadcasted if you're signing on virtually. What do you, tailbone pain's pretty broad. What are you going to talk about in this workshop? Are you going to demo exercises? Are you going to, give people a worksheet to do at home? What are you going to do in your fancy workshop?
Well, we're going to go over anatomy just like we did today. It's always nice to have a review because I think that helps create a map for people. And then we're going to go over a couple of functional movements where they can start to get a better sense of how their pelvis and their hips and their tailbone all work together as a team. And then there will be a little bit of exercise component as well. And people, can participate or they can observe. I always like to say there's a lot of different ways to wrap a present. And so however people feel like showing up that day is wonderful. I did not know that you were going to broadcast it. So
yeah, you're going to, so that we can only do 1 out of the 3.
You chose me.
So I am anticipating it's going to be you. It's going to be, because we're putting you in the biggest room. The other 2 rooms are smaller. One is fertility and the other one is functional medicine. And that should be very, very interesting, but we are going to broadcast the tailbone pain. So the Endometriosis Summit is coming up March 8th through the 10th in Orlando, Florida, and available virtually. Both our speakers tonight will be presenting. For Dr. Fogelson, we're gonna throw a parade because this is his first time attending in person. So we're very.
I know. I think there's 3 years that I say I'm attending, then something comes up and I don't. But I'm 98% sure I'm going to be there. At this point, something cataclysmic would have to occur.
Well, what happens is, and there's a couple doctors who are in this situation, when the doctors are all in a practice together, it's always hard to have everyone. So we have to have Dr. Moling because she's giving a workshop. And then, we know that everybody has to balance. Like we always have trouble getting Dr. Eugenio and Dr. Sinovo because they're in practice together. It's hard to, not everybody can close their whole practice and leave everybody behind.
Yeah,
So,
well, we'll be fine. We have I actually have a real big surgery that week, but it'll involve other general surgeons who will be able to follow with the patient.
all right, fingers crossed. And we're excited to have you. Tickets are on sale, www.theendometriosissummit.com. I hope everybody has their hotel reservations because Amy Stein told me out.
I better do that.
Yeah.
I end up staying on
All
Orange
right.
Blossom
If
Trail.
you have a problem, while we're online and I have you, if you have a problem with the reservations, I may have an override. If attendees have a problem, I don't think I have an override, only for faculty.
I already have my
So
room.
All right.
You are my good one. You have a room. All right. Take care. Next week we are doing appendix endometriosis with a first timer with Rachel Haverland from Texas.
Nice.
And then Dr. Joe, I think, is hosting.
Very nice.
Yes.
Thanks again
All right.
for
Good night,
inviting me, Sally.
everybody. Thank you, Dr. Fogelson. Thank you, Amanda.
Bye.
Thank
Oh,
you.
call me Nick. Great. Thank